It's great to be with you. This is my first photo conference to attend, and so I appreciate the consideration and invitation. This talk that I'm going to give today, normally, it's kind of it's a research talk, right? And if I were at a scientific meeting, it'd be a bunch of highfalutin sort of academics in the room, and I'd be standing behind a podium very formally giving a 12-minute talk and 3 minutes of questions and, that kind of thing. And rather than that, I'm now in front of a much, much more favorable, better sort of audience. As an academician, I think I can sort of beat up on academics sometimes. Some of the questions that get asked in platform presentations are often, very, very pedantic types of methodological nonsense kinds of questions, and oftentimes they miss the sort of the bigger picture of the actual results. And so it's good to be in the company of very motivated clinicians who I think in many ways will be able to relate to some of the questions that we were asking in this particular study, and hopefully through some Q&A and back and forth have some healthy dialogue about what the data mean and what the data don't perhaps mean, and even more importantly, perhaps future questions for research. So it's a real privilege, and if you are one of those academicians, I'm saying my comments obviously in jest. Please don't take it personally. I'd like to thank both Al and Ben in particular for being so gracious with the data set. Some of the questions that get asked of the data set are, clinically oriented types of questions trying to compare, treatment A with treatment B, and they're relatively low on the sort of the political kind of threat scale, so to speak. Whereas basically I went to Ben and Al, this has been a year or two ago or so now, and said, hey, what I really want to do is basically divide your data set in half and pit two parties, hospitals and private practice, against each other in a horse race, and let's see who wins. Right? That's a really low, politically volatile kind of question, as you might imagine. And through some iterative back and forth discussions, and obviously their graciousness, they've always said from the very beginning that with photo, the key, the data set is open. And as long as you ask the questions in the right way and interpret it in the right way, the data fall wherever the data fall. That's one of the beautiful things about data, is data doesn't talk back. It doesn't have an opinion. It is simply presented. And so what I hope to do is a decent job of following through, at least my commitment, to, in a very transparent and credible way, present the data, and then have some healthy dialogue again about what the data mean and what they and what perhaps they don't mean. So what we attempted to look at was essentially outcomes as well as efficiency, so change scores over number of visits between the hospital-based practices within photo and the private practice-based settings within photo. Now Al alluded to sort of my academic background. Just as a matter of full disclosure, I also approached this question as a private practice owner myself. We've got about 15 locations or so between San Antonio and Austin. And some of you may know I'm also affiliated with Evidence in Motion. And so I come at this from a heavy private practice sort of based perspective, and frankly bias, if I can be so blunt. And so as we think and talk through these data, it's important to keep those biases in mind. I hope they don't influence what I'm going to say or not say, but it is important that that those be genuinely acknowledged. Just out of curiosity, how many of you are from hospital-based settings? If we can get a sense from the distribution. So it's more than, is it fair to say it's more than half? Is that fair to say? Okay, private practice folks? Okay, so my guess is I'm kind of round numbers, maybe 60-40 or perhaps 70-30 in favor of kind of hospital-based settings. Okay, it's good. Yeah, here. Okay, excellent. It's good to know. It's good to understand your audience when you're talking for obvious reasons. I'd also like to thank my collaborators, Jeff Harmon and Steve George, Maggie Horn, as well as Jason. They're at University of Florida, and then Jason Rodagero. And certainly, just a tribute, obviously, to Dennis. We started this project with Dennis, before he passed, and he was very instrumental in kind of moving this project along. Judy, can't say thanks enough. Where's Judy? Judy's always extremely gracious, and then Inga has really just been a huge asset for us in the last, at least last 3 or 4 months, as we continue to go back and need a little tweak here, a little tweak there, and so I can't say thanks enough to the entire photo team. Okay, with that said, I don't think it's lost in the room that healthcare costs are sort of spiraling out of control, and we don't need to make, I think, the case here that as you might say, if you were an astronaut, Houston, we have a problem. America, we have a problem with healthcare. And certainly musculoskeletal conditions are a growing part of the cost structure. Unfortunately, musculoskeletal conditions doesn't get nearly the attention that it probably should. You don't die from back pain. I routinely say if only you would die from back pain, we would actually get commensurate sort of funding and attention as things like cancer. And I'm not here to diminish, by the way, the implications of cancer. It's just much easier to tell very compelling stories about cancer because we can all relate to someone that we know who may has passed, and from a public advocacy perspective, being able to tell those stories is very meaningful when it comes to funding priorities, especially at the federal level. Whereas musculoskeletal conditions, it's just back pain, it's just a little knee pain. And yeah, maybe on an individual basis it is, but we have these chronic conditions for a long time in our lives, and they cost a lot of money. Musculoskeletal conditions as a whole rivals cardiovascular disease, diabetes, and in some cases more than all of those. It's a huge issue, and payers finally are starting to recognize it. And obviously we play a big role as physical therapists in caring for those patients. We should play a much larger role, of course, but we play an important role in managing those patients. And there's certainly some data that's starting to suggest that, wow, when we deliver this care early on, good things happen downstream. If you get these folks sort of out of the high-cost centers like drugs and surgery and imaging, and you kind of get directly to see a physical therapist early on, all the things that we've thought happen, like decreased costs downstream, in fact, do tend to happen. In fact, some of these timing issues, we might even argue, are more relevant than even the quality of the care that we provide. Not to diminish at all the quality, because certainly providing quality care adds an extra dose of benefit, if you will. But the process of care issues in managing these patients is huge, and really where a lot of the opportunities lie, especially from a healthcare reform perspective. It's really about getting the patient to the right place at the right time. And when we deliver these services, by and large, as a profession, we deliver these services in either hospital-based settings or in the private practice-based settings. Roughly 34% or so. This is the APTA survey, so bear in mind this is APTA members, which we realize may or may not be reflective of everyone. But roughly 34% of us function in a private practice setting, and about 21% or so function in hospital-based settings. And there's been lots of widespread debate that's gone on about where the best care is delivered. Does it happen in private practice settings because we're an entrepreneurial bunch and we care more than you hospital-based PTs? And I'm saying that obviously tongue-in-cheek, but you've heard some of those sorts of criticisms that are out there. On the other hand, the hospital-based PTs out there would say, well, you money-grubbing private practice, all you guys care about is making money, and we're much more angelic in our motives, and we're the ones that really care about the patients. And again, I'm making exaggerated sorts of statements to make a point, but I think you understand the sort of the natural rivalry, if you will, that can exist between between practice settings. On the other hand, those of us in private practice, right, we would criticize all the costs in hospital systems and the overhead and the fact you guys get paid 30 to 40% more than we do in private practice, et cetera, et cetera. And so why not look at the clinical outcomes and actually be able to compare the two? And so that's really what we set out to do in this particular study. Again, looking at outcomes as well as efficiency between the two practice settings. Now, when we first went down this road, we started diving into the data set, trying to find the variable that says what kind of practice setting is a particular photo client. And we found pretty quickly that that variable doesn't exist, so, at least at the time. So there was no way to sort of determine among the clients who was a private practice versus who was a hospital versus who was a CORF versus who was any other type of practice setting. And so Judy was very, very gracious and sent out a survey to all of their users to basically self-identify themselves as based on practice setting type. You can see here, these are the options. So you could be a private practice, a hospital setting, a CORF, a SNF, you could be a POPS, you could be a home health agency or a rehab agency. And so what we were interested in were these top two. So if you were any of these other ones, and these other ones were a fairly small percentage of the photo database. So even if we really wanted to compare, it'd be kind of nice, right? We hate POPs even more than, as a private practice, we hate POPs even more than we hate hospitals. And again, I'm saying that tongue in cheek. But really not enough data within some of these other categories to make meaningful comparisons. So if you were a private practice or hospital, you got left in. If you were one of these other types, you got excluded. We had a roughly 50% response rate, so we're missing half of the photo data set because we weren't able to categorize them. But nonetheless, given the size of the data set, we ended up still with quite a large sample. This was actually surprising to me, and this was out of my own ignorance. My impression, again, this is where biases come into play, and I'm going to give you one that came into play here. I thought photo, man, only private practice folks use photo, right? Hospitals don't care that much about their patients. And again, exaggerating. And actually it was the other way around. The hospitals are the legacy, apparently, of photo. And private practices now really kind of come on board more later. Is that fair to say in the history? I don't know if that's totally accurate.
It's been pretty much 50-50 all
Okay, so about 50-50 all along. I was surprised that it was as 50-50 as it actually was. That's my point. We had roughly 263 hospital participate and 405 private practices. Now you can imagine that by and large the hospitals had more physical therapists per hospital than there were private practitioners per private practice. And so you can see the distribution of the actual number of patients in the data set was roughly 50-50. So there were about 70,000 patients treated in hospital settings, roughly 70,000 patients in the private practice setting, and that was distributed across 45 different states, just so you can get a sense of the demographics. So we surveyed a total of roughly 1,500 practices. This is where we get the response rate. About 700 of them replied. And again, you can see here the 405 practices with 70,000 patients and the 263 hospitals with again, roughly close to 70,000 patients. And then these other 27 facilities were these miscellaneous categories like CORFs, rehab agencies, et cetera, and those were excluded. Okay, so from a methodological perspective, standard sorts of descriptive statistics just to really describe the sample and see if there were, meaningful differences in various demographic factors between practice settings. And then we collapsed a few of the variables. So we grouped a body region down to 4. We collapsed it into 4 regions. We basically had cervical, cervicothoracic, head, neck, if you will, and then we had lumbopelvic, kind of hip grouped together, and then we had lower extremity as a separate category, and then upper extremity and hand. So we collapsed things like shoulder, wrist, and hand together, for example, because we were interested to see also if there was any interaction between sort of practice settings and body regions. In other words, maybe in private practice we're better at managing, knees, and hospitals are better at managing spines or something like that. So that was another sort of secondary question we wanted to look at. And then we also wanted to look at geographic location. If there were any sort of interactions, in the Northwest, the private practices up there just are really knocking it out of the park compared to hospitals. But in the Southeast, private practice is, performing less optimal than a hospital-based setting. And so we collapsed all the states by region into essentially 4 different regions, sort of Northwest, Northeast, Southwest, Southeast. And then our dependent variables were changes in functional status, so the functional status score from baseline to discharge, or at least the last score that was in the data set. And then we looked at, of course, the number of visits per episode of care, and then from there calculated an efficiency metric, essentially, which is represented as the change in the functional status score over the number of visits. From a data analysis perspective, you can imagine all the potential sort of confounding factors that might interfere with the interpretation of the data, if you will, unless we control for them. So we did adjust for things like differences in age, gender, for example, geographic region, body region, the type of insurance, for example, that the patient had. And then, of course, any number of potential kind of comorbidities, my patients are sicker than your patients phenomenon. So we sort of tried to eliminate that possibility by controlling for things like medication use, exercise frequency, number of comorbid health problems, et cetera, et cetera. And then utilize multivariate regression to look at, again, these differences in practice settings based on both the change score as well as the efficiency score. And then we used logistic regression separately to look at the odds of a patient achieving a certain minimally clinically important difference, which for the functional status score is roughly about a 9-point change regardless of the body region. It seems to be about 9 points, give or take a point or two, depending on the study that you look at. And then all data analysis was done using Stata. Okay, so are you able to see this? You, I think, have the data in your handout as well, in case you're not able to see it. You can see here the distribution of gender. Roughly about 40% or so were male. Average age between hospital, private practice, a little bit older in the hospital-based setting, about a 3-year difference in age. And all of these statistically become significant, frankly, because the data set is so large that p-values get below 0.05 just because you're dealing with such a large sample. So as you look at these differences, you really have to ask yourself the question, are the differences sort of clinically meaningful to you? I would argue that the age, or that the gender is probably not so different. Age, 3 years, depending, might be different from a meaningful standpoint. You can see the activity levels here. Roughly 33% of patients in hospitals didn't perform regular exercise, about 27.8% in the private practice setting. And there were a number of these demographic factors, and I'm not going to really show all of them, but you can see a few key differences, which is why, again, we had to control for these in the data analysis. Here's the demographics based on body region. Probably roughly the same proportion of types of patients that we see in hospital versus private practice-based settings. About 25% lumbar, roughly 12% sort of cervicothoracic, head, neck. The biggest category is lower extremity, roughly 37 to 40% or so, and upper extremity problems about 25%. And I would assume this sort of reflects the kind of the photo experience over time. We did compare, by the way, on a lot of these factors, the responders to the survey versus the non-responders, because obviously one of the questions become, were the respondents to the survey, are they materially the same as those practices who chose not to respond to the survey for whatever reason? And those differences were basically nil. They were very, very similar on these sorts of characteristics. So we feel fairly confident that the data are reflective of the sort of the average photo user, if you will. Here are the differences in payer type, and you can see here there starts to be some differences when you look at private pay, for example, about 30% in the hospital setting, closer to 54% in the private practice setting. You can see the Medicare population, as we might expect, is a higher percentage in the hospital setting versus the private practice setting, which of course contributes to the age differences that we saw earlier, because Medicare folks tend to be obviously the older group. More HMO distribution in the hospital setting, about 14% compared to 7%, and work comp about the same. Medicaid more in the hospital-based setting as well. So again, these certainly, you would argue, are probably material kinds of differences in payer types between settings, which is why we had to control for this in the data analysis. So when you look at these results, just know that payer type is sort of mitigated, if you will, in the actual analysis. Okay, here's some of the comorbidities in hospital-based settings. A bit higher medication use among patients seen in hospital-based settings, about 49% compared to 42% in the private practice group. A slightly elevated number of surgeries, basically 0.45 surgical procedures per patient compared to the private practice setting. Not a big difference there. And about a half to one more additional sort of other health problem, if you will, in the hospital-based setting compared to private practice, and roughly equivalent fear avoidance scores. Okay, now here's the results, and this is where everybody goes either yay or everybody goes darn. And so let's spend just a little bit of time kind of running through them. And these are unadjusted results first. Okay, so when you look at these results, these are not adjusted for things like payer type, age, gender, all those things I told you about. Okay, so we'll look at the adjusted results in just a moment. But the average change score in the hospital-based setting was about 17 or 18 points on the functional status score. The average score in private practice was roughly 16 or so points. Now, depending on sort of your perspective, you might say this is material, or you might look at that difference and go, come on, it's only roughly a 1.5 difference. And if 9 points of change is the magnitude of change that we would say is a minimal sort of clinically important difference, first of all, both groups are almost double the minimum important difference. So we would argue that, regardless of the setting, patients are improving over time. But that, a 1.5 point difference is probably not material, depending on your perspective. However, when you look at the sort of the efficiency, what you start to see is that hospital-based settings achieve that magnitude of change in roughly 2 to 3 fewer visits compared to a hospital-based setting. So private practice on average, it was about 14 visits per episode of care. whereas in the hospital-based setting it was closer to 11. So about a 3-visit difference. Again, this is unadjusted. And you can see here the percentage that achieves this minimum clinically important difference, about 68% in a hospital-based setting and about 64% of patients in the private practice setting jumped over that hurdle of a 9-point change. And again, depending on your perspective, 68% and 64% is a meaningless difference, it's only 4%, or depending on your perspective, that's a lot of patients represented in that 4%. Okay, so again, it's a lot of the interpretation. That's why I want to be careful to share my biases, because I think you can see, depending on how you want to spin the story, if you will, you can start to make a case maybe either way. Regardless, what's pretty clear is hospitals are more efficient at doing it. I think that's, at least looking at the unadjusted results, that's hard to argue against. Now, here are the results that are now adjusted. Okay, so this is adjusted for age, gender, comorbidities. And what you find is that in hospital-based settings, they get roughly a 3-point improvement compared to hospital-based settings. So in other words, the magnitude of difference between hospitals and private practice increased a bit when we adjusted. And the reason why is because hospital-based settings do in fact see sicker patients, right? They have some additional comorbidities. If you're a little sicker, you tend to find your way to a hospital compared to a private practice setting, at least on average, and that was represented in some of the demographics we showed. So when you control for it, the hospital performance, if you will, gets elevated just a bit. So there's now a roughly 3-point difference in change score on average, and they achieved roughly about 0.7 more points of change per additional visit. So those 3 additional points that were achieved in a hospital-based setting, again, those were gained over a fewer number of visits. Okay, does that make sense so far? Okay. So again, unadjusted, roughly about 3 fewer visits in the hospital-based setting. Certainly more efficient care in a hospital-based setting. Because these patients gained about 7 additional points of functional status change roughly over every 10 visits. You get that 7 additional points of change. And again, about 67% achieved the MCID in the hospital-based setting versus 63% in the private practice setting. Okay, so now let's, in light of those sort of results, let's just have some dialogue about the why and the what does this mean and what does it not mean, or does anyone really care? Because I think the discussion that we have, for one, I want to have this discussion because we're actually in the process of writing the paper now. And you can imagine the tug of war that exists naturally amongst an author group. Because your biases come out. Jeff Harmon, for example, is a total academic liberal nut job, and I'm again exaggerating. If Jeff were in the room, I'd say that he has no care in the world about private practice, and he probably hates us, and kind of is more affiliated in medical center with University of Florida, more of a hospital-based kind of a bias, right? So his bias sort of is slanted around that side. My bias is more slanted around private practice, and so I'm hoping that this dialogue we have will continue to help inform the discussion. So you're going to be helping us write the discussion as we speak, because ultimately you want to try to tell the most accurate story. At the end of the day, you really want to try to just let the data, as much as possible, speak for itself. So one of the questions that comes up is, are we just a bunch of money-grubbing folks in private practice, and all we really care about is the bottom line, and you hospital folks are as angelic as you think? And again, I don't think the answer is really one extreme or the other. Most of you in the private practice out there would probably be like me and say, money grubbing? Where's money? Where's all the money? Where's all the money? Right? I mean, the average margin in a private practice setting is something less than probably 10%. So not lots of private practitioners out there becoming millionaires. I mean, there's some really successful practices, but a lot of private practice is very fragmented. About 85% of the market is sort of one or two location practices that work their fannies off just to keep the lights turned on every month. And frankly, from a pure business perspective, have no business even being in practice. I have no idea why they're even in practice, because they sort of incur far more risk than they get reward. And so those private practitioners, if there's any of you in the room, you would look at these data and you would certainly argue that, this whole money grubbing stuff is a bunch of nonsense. I don't see those dollars. On the other hand, are hospitals really that sort of gracious? And what a private practitioner might argue is, well, gosh, yeah, the reason hospital settings see patients in fewer numbers of visits is because they have so many new referrals. They have to discharge patients to keep up with the flow of referrals that are cranking through their system, and that they're overwhelmed with referrals. And so by definition, the fact that there's fewer number of visits actually suggests that there's a problem in hospital-based settings, that they're overutilizing PT. That might be a potential sort of argument that you make. And then someone in the private practice setting might argue, well, hey, what's to say that fewer number of visits is actually necessarily better? Okay? I mean, there's sort of this implicit assumption that less is more in healthcare, especially when you've got costs kind of running through the roof. But maybe there's something to this whole notion of, if we can just tie patients up in a pen as physical therapists and keep them in that pen for the rest of their lives, or they can't get out and go consume things like drugs and surgery and imaging, maybe we're better off. And that those perhaps 2 or 3 additional visits, maybe that buys the patient some time. And then if you were to look at healthcare costs downstream, the cost savings downstream from a private practice delivery system are actually greater than they are in a hospital-based system, because remember, these hospital-based systems are pretty integrated with a lot of these high-cost items in healthcare. There's surgeons down the hall. There's magnets down the other hall. There's x-ray machines down the other hall, right? And so when we put patients in these hospital-based settings, they have more opportunity to consume a lot of the stuff that we know doesn't work and just drives up healthcare costs. So hey, 2 to 3 extra visits, well worth it. And maybe that's one argument. The other issue that someone might argue is that, now wait a second, most patients these days have pretty high sorts of copays, right? And that patients vote with their dollar as to the relative value that they are getting for their service. And so, gosh, the fact that patients are willing to continue to pay $25 to $30 a visit, roughly average copay. Some of you are with payers, the copays are well north of that. Patients are voting with their feet, and they're saying, hey, I get at the end of the day more value out of my care when I go to a private practice setting than I would do in a hospital-based setting. And so I'm willing to pay for an additional 2 to 3 visits that I'm really not willing to pay for in a hospital-based setting, and because I don't like the environment, and I don't really care for the walk that I have to make from the parking garage into the hospital. And so therefore, these additional visits are simply reflecting added value from the patient's perspective. Or perhaps patients have higher loyalty to their physical therapist in a private practice setting because maybe we build better relationships than you depersonalized hospital-based PTs. Maybe that's the sort of the argument. And then, of course, on the other hand, if you're in a hospital-based setting, you could imagine making exactly all these exact sorts of arguments. Again, I'm sort of sharing them from kind of a private practice bias because that's the bias that I have, sort of looking at these data. And yet, on the other hand, there's credible arguments to the contrary as well. And so in conclusion, and then I hope we can have some, nobody's thrown anything yet and no one's left the room, that's positive. We're making progress as a profession. And by the way, before we get to the Q&A, there's far more opportunities for us to collaborate, right, between practice settings. Sometimes we view each other to the enemy. We do this in private practice. We view our private practice competitors as kind of the enemy, and we spend a lot of time beating each other up. Meanwhile, the healthcare pie keeps growing and growing and growing away from the the PT community. We should be spending much more of our time actually working together than against each other. That's a whole other sort of topic. But in conclusion, you can see patients in both settings achieved important differences. No matter how you slant the data, no matter how you're biased, though, it's hard to argue that hospitals are not more efficient in the delivery of the care. Now, whether efficiency is what we're after in healthcare, again, it begs a different question. There's the whole argument of efficiency versus effectiveness. And clearly, in this case, hospitals were sort of more efficient and more effective, right, because they're gaining more points of change over time. But maybe if those additional visits translate into lower downstream healthcare costs, maybe on the global scale, private practices are more sort of effective, perhaps. Now, again, bear in mind, we don't have any of the cost data to look at because back to the whole put my private practice hat on, those of you in hospital-based settings, your hospitals get paid on average about 30 to 40% higher per visit. So my, $90 to $100 a visit is your sort of $120 to $130 a visit on average. And there's no doubt hospitals do have lots of infrastructure and lots of overhead that we get a little better at dealing with in a private practice setting where we're incredibly interested about controlling costs. And so if you looked at overall costs of care, depending on how you do the math, and again, I'm just speculating here because we don't actually have hard cost data to look at, you might argue that the overall costs are still, even with 3 fewer visits, that the overall costs are still much higher in the hospital-based setting just because from a payment perspective, it costs payers more for care that's delivered in a hospital-based setting. And so, gosh, who cares about those 2 to 3 extra visits if I'm a private practice guy because I'm still more cost-effective than hospital-based PTs. Again, hypothetical, but hopefully something that we can discuss. So the bottom line, of course, is as we know with most research, we end up needing to ask more questions than we were actually able to answer with one sort of analysis. And so there's lots of interesting opportunities to continue exploring the implications of practice setting, especially if you can get your hands wrapped around the cost equation to see what implications that has, both direct costs of care, sort of a per visit payment per episode, as well as downstream healthcare costs as well. So with that being said, who wants to throw the first stone? Okay, let's see. You can't let the founder go second, so go ahead, Al.
I want Mark and perhaps Daniel and Inga support me on this if I'm saying right. We know that we have greater change for patients who have more disability or more severity, so that it showed in your data that the patients in hospitals were a little more disabled, if you could use that term.
Correct.
Therefore, they have the potential for more change. Make sense? Clinically, it makes sense to me. So what I would think you could look at, Inga, you may have to help me here, is that you take a look at the intake functional score on the two different patient populations?
And so, very fair question, and yes, I didn't show all the demographics, but the baseline functional status in a hospital-based setting was hot, well, I should say lower. They were sicker. They weren't doing, or they had more disability. I always have to be careful how I say higher or lower. They had less functional status. Maybe that's the way to say it. In the hospital-based setting, but that was controlled for in the adjusted analysis. So we did control for the baseline score. So the data are sort of irrespective, if you will, of those differences because they're accounted for now in the analysis. Let me go to now. I can't let my mentor sort of go last. So Julie, go ahead and fire away. I feel like I'm at my dissertation again when Julie asked the question.
All right, so first of all, I'll claim that
Hey Julie, can you speak up just a bit?
I'm saying my bias and your bias is different on these, because I'll definitely go with the academic liberal pinhead on this one. But this doesn't surprise me at all. I would expect it. And I think I think you're working awfully hard to try to explain it in a way that probably doesn't fit.
Yep.
So I would share that perspective that, to look at 11 visits versus 14 visits and try to read into that with sort of more loyal and satisfied, and that's pretty high utilization in both ways. I don't know that I'm going to buy that, but I think, with that being said, and I'm sure you would share this, I don't view this as saying anything about the character or the motives of the physical therapists that are employed in these settings. I mean, systems get the results that they're designed to get. So a system, with respect to pain modeling, looking at a practice business and hospital business, these data are absolutely predictable, especially with respect to I would be cautious about attributing it to motives of therapists, because I know you're playing on but I'm also curious, my personal thought on this is there's also a very perhaps regional character to this that I'm sure you and everyone in the room knows hospital settings that don't behave this way and private practice settings that are different or at least perceived to be locally. So I'm wondering if there were any interactions with you, and that makes your geographic region may not be discrete enough to really find those variations. And then I'm also curious, you mentioned looking at interactions by body type. So I was wondering if
Yep.
any reports could be found in there.
Yep, you bet. So that was a mouthful, so make sure I address each of the issues. And to Julie's point, I completely agree. I'm sort of exaggerating the case for the sake of discussion. If I were up giving a scientific sort of platform presentation, I would not have said half of the things I've said. I would have already been thrown out of the room. So I hope you do keep that in mind. I mean, I'm really trying to speak for the sake of sort of illustration, even to the point of perhaps exaggeration. And I agree completely that there's, I don't question the motives of folks in really either private practice or hospital-based systems. As human beings, what we know 100% certain, we are functions of the incentives that are placed in front of us. We behave according to ways that ultimately benefit us. I don't know, is that pretty fair to say? I'll give you a perfect example. In the DoD setting, for example, the average number of visits for these sorts of patients is off the charts lower than both hospital-based settings and private practice settings. We're so good in the military that we get patients better in only like 4 to 5 visits for back pain. That's how good we are. And I'm again saying that for the sake of total exaggeration, because that's also not true. What is true is that our incentive is to work less, not more. I get paid the same. Doesn't matter how many patients I see. It just is kind of irrelevant, and it's next to impossible to fire me. So we're kind of lazy, in fact. And again, if you're in an audience of military therapists, you'd hear military therapists singing their praises about how great they are and all this kind of stuff. And that's just not entirely accurate. We behave according to our incentives as well. Now, the interactions. Yeah, now Julie's asking the science question. So we did look at the interaction of body region. That's been analyzed. I didn't show all the data up here. And there was no interaction based on body region. There were no differences between practice settings. This trend, in other words, was similar regardless of the body region. What we have not done yet, and Jeff just wasn't able to get it done before the meeting, is look at the geographic region interaction. We will have that, though, in the paper itself, because that is a very interesting sort of question. We know that geographic region has a lot of implications for other things like surgery, for example. The notion that whether you're going to have spine surgery really depends much more on your zip code than it has anything to do with your spine. And perhaps there's some differences in regionally based. Maybe Photo has just some amazing hospital-based systems in certain parts of the country that are not as sort of elevated or good in other parts of the country. And but we'll be able to look at that. Yeah.
Is there a difference in the number of patients seen per day in separate settings, or whether they deliver pure one-on-one care to the patients?
So the question has to do with the number of patients seen per day in practice settings. We started to go down that path, but we ended up having to do too many kind of estimations. So if you look at, so we don't know, for example, we don't know how many therapists are necessarily represented by each of those practice settings. I suppose we could look at it. I suppose we could, currently the data is nested in such a way that the therapists are collapsed within a practice setting. I guess we could, within the data setting, could we count the numbers of physical therapists and make estimates about number of visits per day? I assume we could, but what we don't know is how many incomplete data sets that there are. You know what I mean? So there's a lot of patients that we're seeing or that are not in the data set. So it's a little difficult to sort of make those ultimate judgments about visits per day per sort of FTE. I mean, again, we've all probably got our bias. We work really hard in private practice. Hospital-based PTs do one-on-one for 8 patients a day kind of a thing, which again I realize is not entirely accurate. And by the way, some hospitals are money-grubbing hospitals too, potentially, right? I mean, hospitals are starting to implement more and more kind of practice management systems, and so those of you in hospital-based systems, you might take offense to this notion that you're not working your fannies off, seeing patients in a very busy sort of a schedule, and that's a fair potential argument as well. Yep.
I have the thought with the private practice setting, the system doesn't allow or doesn't account for what kind of private practice setting do you have. You have one in which the therapist sees the patient for the initial eval and potentially not for another 8 visits, and they're being seen by an aide, or they're doing exercise in the gym by themselves, or is it one-on-one with a licensed therapist?
Yeah, fair. So good point. In case you didn't hear it, the care delivery models might be different. Even from private practice to private practice, some do this sort of one-on-one thing. Some utilize other support personnel to the extent their Practice Act allows it. The same trends probably happen in hospital-based settings as well. Whether those care delivery sort of models are similar or different, you can't look at within obviously the photo data set. We don't have that, but it's an interesting point. Selena?
In photo though, you can state how much percentage of your time was spent. You're not looking at that in the discharge stuff then in the photo, because you can state how much of percentage of time is with the physical therapist and assistant.
Yeah, the issue is that's not very populated. You know what I mean? And so it's because we tried to look at that and we had to ignore. I mean, it's just not there. By the way, Inga, to the same issue, we did look at the patient satisfaction variable, and Inga did yeoman's work to get us the satisfaction data. The problem is there's no data there, and I shouldn't say no. The satisfaction survey within photo is not widely reported. the scant data that was there said it was about the same between private practices and hospital-based settings. So I think it's probably fair to say it's similar. So my whole argument about maybe patients being more satisfied in private practice probably doesn't fly, but the data wasn't there enough to really comment on it. Selena, one more follow-up?
The question I had was, when you wrote out your patients, you went having an onset of pain in 22 days or more. That both look pretty equal in the two settings, but what if you went one step further and said 6 months or more? Because you know the longer the duration
Yeah.
of pain is there a different type of population between the two potential facilities?
Yeah, and that's why, because to your point, you could cut off chronic at whatever cutoff you wanted.
You can't really get into chronic. I mean, 22 days.
Right, but we did look at a number of different sort of comorbidities, so we weren't just sort of counting on one particular variable. And by the way, when we looked at that greater than 22, because people do ask, well, why 22 days? I forget the question. It's in photo. I don't know. I don't have the question to show you, but patients categorize themselves in like 4 or 5 options, I think. Does anyone know? If you know, speak up. And the options are something like 0 to 10, 11 to 22, or something like that. And we just collapsed the categories for the sake of illustration. There's no question in photo that says, how many days have you had symptoms? And the patient says, I've had symptoms for 300 days. Or does it? Yeah. But the variable we used, we ended up collapsing it. Yep.
One of the things I like about photo is it looks at your change versus the predicted change, and you didn't look at that in the study, correct?
So help me out. The predicted change.
Patient coming in, they may say, their predicted change if they're like in the hospital setting in Medicaid or Medicare, their predicted change may be like 13 points. And if they're an athlete who sprained their ankle and just came in right away in private practice, the predicted change may only be 8 points based on the risk factors.
Right.
You get a percentile ranking based on that. So when you just look at the change score, it's almost a raw score in itself because you're not looking at what actually the predicted change would be.
Yeah, and so I totally hear what you're saying. I think we indirectly, though, ended up doing that by adjusting for all of those other sorts of factors. Because your point's well taken. I mean, some patients that are sicker are going to, maybe have more difficulty recovering and may need to be seen more intensely, those kinds of things. But because we adjusted for it in the analysis, the results are fairly on par. I mean, at least to the extent we controlled for things that we could control for. There are other confounding factors that we don't have, like care delivery models, for example. If those are dramatically different between hospital systems and private practice systems, that could confound the outcomes or explain why the differences are there.
Well, one of the things I'd be interested in is, I'm a private practice owner, so when we look at it, we look to see what our percentile ranking is based on photos of millions of cases before.
Right.
So to see in this study the outcomes based on the millions of cases.
The percentile ranking.
I mean, I
Yeah.
know you went in and did it yourself, but that doesn't necessarily compare it against the millions of
Yep.
cases that it should predict.
Yep. I tell you what, why don't you ask Jeff Harmon that question instead of me? Because if you're the guy on the other end doing all this work, anyways, you can only go back to the well so many times, especially when you're doing it for free. Yeah, in the back.
So if you look, I'm actually a little bit surprised by this.
Do you mind speaking up just a little bit? It's my hearing, sorry.
I'm a little surprised by this. That's not at all what my experience is. And, we do get a lot of participation in more just functional alignment. But I would say for the future, one of the questions I would ask, when we see this coming out in the research and combine it with photo, would be the type of advanced training or people who have postgraduate advanced training and the type of treatment response to those, and does that make a difference in your effectiveness?
Yeah, fair question. I mean, so it would be ideal, right, if we had a demographic sort of survey of every, physical therapist and their requisite training and try to look at, whether there's an interaction with characteristics of the therapist. Maybe regardless of the practice setting, if you've got some sort of credential or level of training, maybe you're better, maybe you're not. So yeah, fair question. I'm sorry? Yeah, and I just mean in the context, you're correct, there are folks who've looked at that, we just don't have the ability to look at it in the context of this particular data set.
Yeah, to me, I've been quite a bit of time in both private practice and hospital setting. And I think one of the take-home messages from this is 50-50 is probably still the bottom line here. And I would suggest that folks who have entered into something such as photo for feedback have already put themselves in a position where over time there really should not be any difference. And I would be surprised if you did the study 3 years from now, you would see virtually no difference. Just because you've already made the decision that you're going to put yourself out there against a number and challenge yourself to make whatever change you need to make. And in terms of the hospital, I would also argue that in hospital settings, it is not just the physical therapy departments who are trying to become more efficient. It's basically a global process. So in our cases, it was from within our department, but other hospitals, it's from top down, and where the whole system is trying to address this. In our case, we chose photo as the benchmark.
Yep. Yeah, I mean, certainly what I think is true, and again, I have no data to back this up, if you participate in photo, you're a self-selected sort of bunch of maybe higher quality caring therapists. I don't know if that's fair, but at some level you really want to measure your outcomes. You have some element of an understanding of accountability to outcomes. Whether so what about non-participating clinics? Is this distribution the same if you don't participate in photo? And I don't obviously we don't know the answer to those questions. Are the practices who participate materially the same as those who don't?
One thing you could look at is along that same line is the length of time that each facility has been on photo. And you look at that, I think I heard you say early on that hospital-based practices jumped on board with photo early on.
Well, yeah, and what Al's saying is that, because I hear what you're saying, what Al was saying, though, is the distribution was roughly the same from the beginning, that it's sort of always been a 50-50 roughly split. And when you say 50-50, I think he's referring to numbers of cases in the data set, because what is clear is that there's more private practice facilities than there are hospitals, but the hospitals are bigger facilities with more therapists and more patients, so that on average the number of patients are roughly the same. If you actually count your clients, like by client type, there's more private practices than there are hospital-based settings. So your point's well taken. If there was a trend that like hospitals have been legacy sort of participants for a long time and they've kind of maximized their sort of learning curve, and boy, they really manage, we know that we manage what we measure. And private practices are newer, maybe the learning curve is still going up in the private practice setting. But that doesn't seem to be the case based on history, but it would be interesting to look at the length of time that each client was there. I don't think we have that data set, Inga. And Inga's going to tell me, no, we don't, whether we do or not, just because she... No, I'm just kidding, because she doesn't... Yeah, exactly. So... Yeah, exactly. Yeah. 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 In other words, is there a difference in the sort of the employment of physical therapists into private practice and hospital-based settings based on age? The new grads these days are sort of Gen Y types that want the easy life of the hospital setting. And again, I'm exaggerating. No, and again, I'm not. I don't know. It'd be interesting to look at that, and we just don't have those characteristics. Yeah.
I think it's really hard nowadays in this room to talk about outcomes and costs at the same time you have to do anything. It's hard not to. And I kind of hear that systems and incentives may be driving more of the direct cost in this research than it's hard to measure, but that's kind of my perspective. So if you transport this and redo this study, say 3-4 years from now, payment methodology has changed more towards global total cost of care or bundled care, and then risk sharing contracting. And I think for the independent or private practice to survive, they probably have to be involved in a collaborative relationship with a health system, a hospital-based system in order to survive. How do you think the data would look in that kind of a system? This is in our day and age of still fee for service, counting visits, all that.
Yeah, I mean, I think what you're arguing, and I think is probably true, is that as we move to a more centralized healthcare system, the delineation really between hospital settings and private practice settings are probably going to start to blur a bit. I mean, even hospital-based settings now, as they've been going out and gobbling up primary care groups, are now starting to want to gobble up rehab groups for the same sort of reason, because everyone's kind of preparing for this accountable care kind of context. So what used to be private practice in this data set going forward could be greater representation within sort of a hospital sort of led system, whether it's through a direct acquisition or even through just joint ventures and such, like you see with Select Medical, for example, in Texas. I know has a joint venture with the Baylor hospital system, and so you have private practice delivering hospital-based care. And so who are they? Are they private practice, or are they hospital? Are they corporate? Ability to sort of self-identify into these discrete categories, I think, becomes more difficult going forward. Yep, go ahead. Whoever speaks up first.
What was the difference in completion rate between hospital and outpatient or private practices?
That's a fair question, and I don't know. Yeah, I don't know. I'm virtually certain we looked at that, because that was one of the potential kind of confounders. I don't have it here, and I don't know offhand. I'd have to look at it. I'm going to guess the completion duration was roughly the same. I know we looked at it, and if it were somehow different, we would have controlled for it, and we didn't. So I'm fairly certain it was the same, but I don't know exactly even what the completion rate was.
Was there a difference in patient satisfaction? Did you look at that?
Yeah, that's what we were kind of discussing earlier. We tried to, and it's it was less than like 5% of these cases had satisfaction data in it. So the cases that were there, it was roughly the same. Whether that's representative of the full sample, it's really hard to know, because it's just not there a lot.
That was my question, but in your response, how do you come up with just 5% completing the satisfaction component? Isn't that part of the discharge process?
I don't guess it's mandatory, or so. I mean, it is? Yeah.
If they do status, they automatically get a patient's.
You can turn that off.
Yeah.
Only 5% need.
Yeah. Well, and again, let me, as a caveat, some of this stuff was happening within like the last 48, 72 hours. Julie can relate to this. So it's as we sort of get into the more definitive, I mean, that's why having these sorts of discussions is very, very helpful, because I've got mentally now like 5 or 6 things that we're going to be looking at in response to the dialogue. So it's also possible that we haven't fully looked at it. Jeff has been very gracious as I've been pinging him over the last few days. Yep.
I have a question with your assumption about cost too, and
Mm-hmm.
hospital-based has a higher percentage. We saw those initial statistics.
Yeah. Yep. Yeah, and hospital-based payment is also going down. I met with a VP of Baptist, one of the hospital systems in San Antonio, and so sort of making that argument, and he just started laughing, and he said, "Well, let me show you our financials. They're not nearly what they were, and on the PT side, the difference has shrunk now to about they about 10 to 15% more." But not the 30 to 40% differences that kind of has been sort of more common in previous years.
I was also going to comment about the cost of care is, we're talking about cost of care to the health insurance company, but there's also the cost to deliver the care.
Sure.
So the hospital organization or the private practice incurs a certain amount of cost to deliver every visit, and the operational margin or how much we're getting reimbursed from the insurance company would be a little bit different.
Right. That's correct. So one more question, then we got to go.
I just thought it was interesting also that not the copay with the payer source, but also what if the hospital-based systems have more Medicare, Medicaid with limited number of visits, and if that's driving our number of visits being less?
Yeah, we controlled for payer type. So to the extent that payer type drives quotas on visits and such, that should have been reflected, in the analysis. Okay, great. I think we're at a breaking point for lunch. Appreciate the dialogue. It's been very instructive for me. And again, that's half the reason I kind of stepped on the ledge just a bit. And so I really appreciate the dialogue. Al, you got a message for us?